Welcome to Myasthenia Gravis and the Complement System, Treatment Options. I'm James Howard, Chip Howard to many of you, Professor of Neurology, Medicine, and Allied Health at the University of North Carolina at Chapel Hill. These are my requisite disclosures. This educational program is funded through an unrestricted grant from UCB, an acknowledgement to CheckRare CE for their production. Let's begin. We talked about burdens of disease and its impact in terms of the quality of life and the activities of daily living. We clearly have increasing data on the impact on employment and muscle strength, etc. But there's also burden of treatment, and that's predominantly the adverse event profiles of the drugs we use and the logistics and how we can manage it. And at the top are those common therapies that we use. Cholinesterase inhibitors to the left, steroids, immune suppressant therapeutics, intravenous immunoglobulin plasma exchange, and rituximab. And one sees the list of side effects, potential side effects that can be encountered. And this is over short-term as well as long-term use. In addition, with some of these, there's an even more dangerous long-term use. For instance, with steroids, the potential to develop diabetes, osteoporosis, hypertension, to say nothing of weight gain. With many of our immune suppressants, there is malignancy risk. There's potential damage to the liver and to the kidney. And similarly with plasma exchange, we have a number of thromboses that have occurred with IVIG. We've had infection and sepsis with catheters used in therapeutic apheresis. And with rituximab, although exceedingly rare, progressive multifocal encephalopathy, PML, is of a concern. If one looks at registry studies, adverse event distaste represents about 45 or 40% of our patients. However, if one is on corticosteroids, that distaste goes up over 80%. While a very effective drug, it's a two-edged sword, and it's linked with all of these significant adverse events. Hence the need for new therapeutics. In addition, many of the immune suppressive drugs that we use, the cyclophilins, azathioprins, mycophenylates, cyclophosphamide, etc., have a very long latency from drug initiation to onset of effect, to say nothing of maximum effect. And in many instances, this is 4 to 6 months, and with some, it may be almost a year. Clearly, that's lost time for the patient. And again, a need for new therapeutics with restricted adverse event profiles and more rapid onsets of action. And you've seen this graph before, the history of treatment options, our mortality rates, and in this decade, patients should live a full life. Some literature would suggest 3% do not. But it's all my personal belief that if appropriately managed, individuals should not die from their myasthenia gravis. The two latest classes of therapeutics, complement inhibitors, as well as neonatal FC inhibitors, have rapid onset of effect within days to a few weeks, with maximum effect occurring within 3 to 4 months. Now we have multiple ways to treat myasthenia, and this is a cartoon that demonstrates. Classically, cholinesterase inhibitors, a symptomatic therapy, has been used in myasthenia with a relative improvement in some, but not all, muscle groups. Interestingly, those individuals with MuSK myasthenia do not, or often do not, respond to cholinesterase inhibitors. We can also use corticosteroids. They target the immune system broadly. Same with most of our immune suppressive drugs. but it's with the complement inhibitors attacking the terminal complement pathway through complement protein 5 that much of our improvement of late has occurred. As we said previously, we have several FDA-approved treatments. In the neonatal FC receptor class, we have efgartigimod, which is used intravenously. We have efgartigimod in a subcutaneous formulation. This has been co-formulated with hyaluronidase because of the modest volume that's injected. We use the hyaluronidase to break down local collagen tissue and allow this volume to be absorbed very easily. This process has been used in oncology for more than a decade and very successfully. And more recently, we have rozanolixizumab, or ROSI for short, which is a subcutaneous infusion. These are either administered on 4-week schedules or 6-week schedules, and retreatment occurs when the patient has clinical deterioration or worsening. Complement inhibitors, initially eculizumab, a monoclonal antibody targeting C5, administered intravenously. Ravulizumab is actually eculizumab, but engineered genetically 4 amino acids to give it a longer half-life. So rather than every 2-week infusion, every 8-week infusion. And zilucoplan is very unique. It is a 15 amino acid macrocyclic peptide, but the targets of all of these drugs are the same, complement protein 5. Efgartigimod, the FC receptor, was approved in 2021, and it's approved for those who have generalized MG who are AChR positive. The initial trial was done in all individuals, and we saw very similar results whether one had antibody or not, but the approval process, because of the outcome measures, etc., for those who had AChR positive disease. The dosage is listed there, 10 milligrams per kilogram, weekly for 4 weeks, and then we base it on clinical evaluation. The subcutaneous form is similar. That dose is a bit different, and it's adjusted to have equal efficacy in the trial that we performed with it. And this subcutaneous injection over 30 to 90 seconds, and currently by a healthcare professional, though our hope is at some point it will be self-administered. ROSI was approved more recently in 2023, and its approval is for those who have generalized AChR positive or MuSK antibody positive disease. It's dosed based on body weight, and it's weekly for 6 weeks, and then again, subsequent infusions are based on clinical response. This requires an infusion pump to be administered. All of these drugs that we've just mentioned do not have any black box warnings. Let's turn to complement inhibitors. And the first was eculizumab in 2017, and again to treat AChR positive generalized myasthenia gravis. The FDA approval was for any individual with AChR positive disease. It's been used because of health ministry and payers restrictions to those who have failed other forms of therapy. It's dosed with a starting dose for the first 4 weeks and then followed by a maintenance dose, which is slightly more on an every 2-week basis. The infusion is short, about 30 to 40 minutes. It does have a black box warning because complement inhibitors increase the risk of encapsulated bacterial infection, predominantly Neisseria meningitidis, and in rare instances, Neisseria gonorrhea, and then streptococcal pneumonia and H. flu, the latter two in children for those who are quite infirmed. This was the REGAIN study. that was performed. This was the phase 3, and one sees the protocol where screening occurred. Standard of care was administered and not changed during the course of the study, and one had to be vaccinated against meningococcus to gain entry into the trial. And we'll come back and talk about the role of vaccination towards the end. 1-to-1 placebo, blinded for 26 weeks, and then those who completed that trial were allowed to roll over into an open label extension trial. And one looks at the right to the drug and placebo drug arms. They were very well matched in terms of age, in terms of gender. Like all myasthenia trials, predominantly Caucasian, with very few other races, although here, because we had Japanese centers, there were Asians, here 16 of them. And disease duration was long, nearly 10 years in both arms of the study. These are the results of the eculizumab trial. I want you to look at two portions. The first is on the left. One sees a vertical bar that splits the screen, so to speak. That first portion is the blinded phase of the trial. Red is placebo, blue is active drug. I'll call your attention to the fact that all MG trials have a significant placebo response. That can be as high as 60% in some trials, on average between 35 and 40%. But also one sees in the drug-treated arm of the study a very rapid and robust response occurring within the first week and seemingly stabilized around week 4 to 12 and then carried through to the end of the 26-week period. At the 26-week period where patients rolled over into the open label extension, at which time the placebo arm receives active drug, there in red, one sees a virtually identical curve to the original start of the study. And that placebo arm now, without a placebo response, because it's already built in, if you will, a rapid, robust response that then parallels the drug arm all the way out to 130 weeks, which was the termination for this data acquisition. On the top, we're looking at the Myasthenia Gravis Activities of Daily Living score, which was the primary endpoint. The MG-ADL is mandated by the US FDA as the primary outcome measure in all phase 3 MG trials. And below that is the quantified MG score, QMG, and one sees very similar responses. The ADL score is a patient-reported metric, physician-administered, but patient-reported, and therefore has more noise in it, whereas the QMG is a physician-derived outcome measure, and therefore the placebo arm is less. When we look at the adverse event profiles, one sees very similar responses between placebo and active drug in terms of headache, in terms of nasopharyngitis, diarrhea, and upper respiratory tract infection. Some individuals had a greater incidence of URIs in the drug-treated arm, but nausea, for instance, is similar. There were MG exacerbations, more commonly in the placebo arm, and one sees other adverse events in excess of 5% that are reported. But relative to the toolbox that we have currently, these adverse events are much more narrow and much less severe than we commonly deal with corticosteroids and azathioprine, mycophenolate, etc. Ravulizumab, I said, approved in 2022, is eculizumab, but engineered for an infusion of every 8 weeks. Because it's a complement inhibitor, it too carries the black box warning for meningococcal infections, and one must be vaccinated against it. This was called the Champion trial. Again, there was screening. Standard of care was maintained throughout, and then randomized to active drug versus placebo, and then those who completed the trial roll over into an open label extension. Unlike the REGAIN trial, where patients had to have failed at least 2 immune suppressive drugs in the prior year, or failed 1 drug but required chronic IVIG or plasma exchange, ravulizumab was open to everybody with AChR positive MG. They had to have a disease duration of at least 6 months. And one again sees that the demography of these patients were quite similar. Again, predominantly Caucasian population with significant numbers, but much smaller Asian population, and then very rare involvement with other ethnicities. When we look at the severity of these patients, and again, most of the MG trials are quite similar, predominantly class 2, which is mild, class 3, which is moderately severe disease. Rarely do we have those who are severely involved because they tend to be poor clinical trial participants with a high rate of dropout due to worsening of their disease. But one sees that the MG-ADL score is almost 9, the QMG score 14 to 15, suggesting that these individuals have substantial disease burden. This graph looks very familiar to what you saw with eculizumab, placebo in red, active drug in blue. The time course is different. What you saw sort of appears to have lesser slope, but in fact, it's very similar. Rapid, robust response occurring within 1 week, with the nadir reaching around 10 to 12 weeks, and then sustained through the to the open label portion. And this is the activities of daily living score. Here, a virtually identical graph with the QMG score. Its safety was virtually identical to that which we saw with eculizumab. Predominantly grade 1, mild adverse events, and very few severe adverse events. There were some that felt to be related to the clinical trial agent. There were 4 deaths. These were unrelated to the drug itself, but were COVID, etc. The open label extension demonstrated findings much similar to what we saw in the blinded phase, as well as what we saw with eculizumab. There were no new safety signals. There were 6 serious events with listed here: dysphagia, tendonitis, worsening, myasthenia, pneumonia, mitral valve. These were not felt to be related to the active drug. In each of these trials, there were no cases of meningococcal infection. My personal belief is that this is a numbers game, and patients who are on complement inhibitors will be exposed and will develop meningococcus. But given vaccination, given education, these should be quite few, far between. 4 deaths, COVID-19, and a cerebral hemorrhage, as previously noted. So Iluka plan is a bit different. Approved here in 2023, it's a small macrocyclic peptide. It's subcutaneously administered on a daily basis. It's an aqueous solution. The injection takes less than 30 seconds. And this drug may be stored at room temperature. And as a result, offers the individual freedom of travel. One can put their syringes in their suitcase and go. The businessman, the family that's on vacation, or the student that has a very complex schedule and is on the move, if you will. And so there are some advantages in that regard. The RAISE study, as it was called, it was similar in design to what we saw with the first 2 studies, though the duration of the study was 12 weeks rather than 26 weeks. So patients were randomized, standard of care was maintained, patients were vaccinated, and then randomized to placebo or active drug. The dose that was used, 0.3 milligrams per kilogram, was chosen because our phase 2 trial looked at 0.1 milligram per kilogram and 0.3. And while patients got better at the lower dose, we had our best response with this higher dose, and that's why we chose it for the phase 3 trial. As you can see on the right, the demography was quite similar to all of our previous trials, predominantly Caucasian, secondarily Asian, and disease class, predominantly class 2 and class 3, with a few in the range of class 4. The MG-ADL score and QMG scores were similar, indicating a fairly significant disease burden. The ADL score in the range of 10, QMG score in the range of 18 to 19. Here is the blinded phase of the trial. Again, very rapid, robust improvement in the purple, which is the blinded drug, and then in the placebo arm, the placebo response in green. And this is the MG-ADL score, which again was the primary endpoint as mandated by regulatory agencies. You've seen the graph on the left just previously. In the middle is the quantified MG score, very similar. And then to the right is what I call the Christmas tree plot. And we were looking for 2-point changes in the MG-ADL score. But if I increase the stringency of response, what percent of the population had a 5-point change, or an 8-point change, or a 10-point change in terms of active drug versus placebo? And the more stringent I become, one sees a shift in favor of active drug. Below the large horizontal bar is what I consider the roots of the tree, and here we favor the placebo. These are individuals who had no change or worsening, and predominantly they were in the placebo arm of the trial. This shows the rollover phase, the open label extension phase. It was called RAISE XT. And again, on the left of the MG-ADL score, you've seen that which is in the white box already, and the dashed line is the placebo arm. And that rollover into the open label extension here in light blue, one sees again a very rapid, robust decline in the MG-ADL score that paralleled the original decline that then parallels that group that was already on active drug. And one sees additional improvement, suggesting that over the course of 24 weeks, there was still ongoing improvement in this metric. To the right is the QMG score, the first secondary endpoint, with a very similar response rate in the blind as well as the open label. So what are the pearls? MG is a clinical diagnosis, and I can't stress that enough. I've heard of a new quote that I think is very applicable. The problem with language, as we listen to reply, we do not listen to understand. And it behooves us as clinicians to listen and take a detailed history. The answers are in the nuances of the history. And we confirm this with our examination, and then also confirm it with serology electrodiagnostic testing. Our overarching goal now in current management is that patients have no symptoms with grade 1 or less adverse events. We've not been able to say that in the past using our current toolbox, our old standard of care, non-specific immune suppressive drugs. But I think we can achieve this goal with new targeted therapies. Clearly, our targeted therapies offer faster onset of action, and the adverse event profile is much more narrow than what we typically use. Complement inhibition targets the terminal complement pathway to reduce the formation of the terminal complement complex, the membrane attack complex. whose function is solely to architecturally destroy that neuromuscular junction. The complement activation is mediated by the presence of antibody to the acetylcholine receptor, and the binding of antibody activates C1QRS. Notably, patients with MuSK myasthenia do not activate complement because their antibodies are predominantly IgG4, and that minimally or doesn't even activate the complement system. All patients receiving complement inhibitors must be vaccinated against Neisseria meningitidis, according to local guidelines. In the United States, that's with a quadrivalent vaccine, as well as the B serotype, ACWY, and the B serotype. And the vaccines are different depending upon which one's used. The schedule of inoculation may be different. So one must carefully look at the product insert and do it appropriately. If one cannot vaccinate prior to the initiation of drug, then these individuals must be covered by an appropriate antibiotic. And remember, there are classes of antibiotics that have the potential to acutely worsen MG, so one must choose wisely. In addition, patients should be educated about the signs and symptoms of Neisseria infection. And all patients should carry a safety wallet card that they can give to their healthcare provider to let them know that they're on a complement inhibitor. And with that, I thank you. Have a good day.